This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, this is Halley Alexander from Wake Forest University. Today I'm bringing you some highlights from the American Epilepsy Society meeting on a topic that's very relevant for all neurologists, the topic of psychogenic non-epileptic events. And I'm here today with Genna Waldman from the University of Pennsylvania, and she gave an excellent talk on this topic at the annual meeting, so I'm really excited to share her insights with you today. Genna, thanks for joining us.
Thank you for having me.
One thing I want to discuss right off the bat, I noticed in your talk, the term we're using now is psychogenic non-epileptic events, or PNEE, but of course, sometimes we'll see psychogenic non-epileptic spells. In the past, they've been referred to as pseudo-seizures. Can you just talk a little bit about if there's a difference between those and what exactly is the best term to use now?
What's the best term for this disease is an ongoing debate. I think it's important to remember that this disease falls into the general group of functional neurological disorders in the DSM-5. But among neurologists, like you said, some people call it psychogenic non-epileptic seizures, psychogenic non-epileptic events, functional seizures, or even dissociative seizures. And going forward in this talk, I am going to be using psychogenic non-epileptic events. I find that it can be confusing for patients to use the word seizure in the disease label when then I'm going to go on to tell them that they don't have seizures and don't have epilepsy. So the name can be different when you read different references, but in general, it's all the same disease. And it's a disease where the clinical semiology has no electrographic correlate, and it's not epilepsy.
So what are some of the key things that we should remember when we're trying to deliver this diagnosis of PNEE to patients?
A theme of us talking today is certainly going to be that accurate and proper diagnosis is really key to the prognosis in this disease. And I think there's an appropriate way to approach a patient about this. PNEE, I think, is very challenging both for the patients that deal with this disorder and for practitioners. To best care for them, a multidisciplinary approach with neurologists, psychiatrists, and mental health care providers together really gives the best care. That's not always available, and it's often the neurologist that's giving the diagnosis, and we're seeing these patients a lot in our office. I think the things to remember when you're talking with your patients is to use really clear language. This is an established diagnosis. This is a real disease, but this is not epilepsy. And once you've done the proper testing, which we'll talk about, I think, in a little bit later, further testing is not required once we give the diagnosis. I think it's really important to provide guidance and education to the patients that PNEE is not volitional, and it can be just as unpredictable as epilepsy. And communicating that can help provide validation to the patients that their symptoms are real, confidence in their providers that we know what this disease is, and to help them engage in treatment in that multidisciplinary approach and give them hope that resolution of symptoms is achievable.
And now you mentioned, that giving the diagnosis, accurately and clearly can impact the prognosis. So can you talk a little bit more about that?
Exactly. Accurate diagnosis to this disease is really so key. The longer the duration of symptoms are tied with a poorer prognosis. So really an emphasis on doing proper testing and providing the patients a comprehensive diagnosis is what's going to impact their ability to have some resolution or improvement in their PNEE disease. The International League Against Epilepsy recommends video EEG monitoring as the most comprehensive evaluation to both evaluate that clinical semiology, what does it look like, and how does it differ from epilepsy syndromes, particularly that frontal lobe epilepsy syndrome, and with that EEG ictal correlate to see that there's no actual EEG changes with the event. However, if an experienced clinician sees the semiology either in the office or on video, and you have an ambulatory non-video EEG that has the event without the ictal correlate, that's also sufficient to make this diagnosis. And I think a really good point to remind our listeners and all of our physicians and practitioners who are dealing with this diagnosis is there was a nice review by Dr. Stone in the British Medical Journal that reported the misdiagnosis rate for these functional neurological disorders is quite low, around 4%. So if you feel like you have the expertise to evaluate these disorders and are familiar with the clinical semiology and how it differs with epilepsy, you should have confidence in your ability to make this diagnosis. And if there's no interictal abnormalities on that prolonged EEG monitoring, 24 to 48 hours, you really shouldn't have that much doubt that you're missing an epilepsy diagnosis. And this diagnosis is critical. Just with the diagnosis, on average, 50% of patients will have resolution of their PNEE when leaving the epilepsy monitoring unit or getting that comprehensive diagnosis in the office. And so we really need to emphasize how important and valuable the diagnosis is to these patients and to their prognosis with this disease.
Those are all really excellent points. And I think it's important to remember, especially if you're at a tertiary center where you get a lot of refractory patients, it can seem like the misdiagnosis happens more often than it does. So it's helpful to remember that it's really only 4%.
I wanted to make another point and draw attention to kind of two groups that have done a lot of work in this area around diagnosis and prognosis. Vobler's group in Germany did a prospective study following patients after the diagnosis in the EMU, and they had resolution in patients about 25%, but that was maintained even 2 years after the diagnosis. There's several other studies that look retrospectively after the diagnosis in the EMU and then following their charts. Specifically, Asadi Puya has done a lot of work in this area. And even in centers that don't have access to psychiatric care, 52% of patients can remain event-free following the diagnosis of this disease.
Now, when we're diagnosing this, I know sometimes in the back of our minds is just that concern that maybe they have psychogenic non-epileptic events and an underlying epilepsy that we, are afraid of missing. So can you talk about how common that overlap actually is?
We definitely know both diseases can occur together. About 10 to 25% of people with PNEE, psychogenic non-epileptic events, will also have epilepsy. So it's not the majority, but certainly there is a proportion of patients who have them both. In terms of those that have both, there's similar rates of drug-resistant epilepsy, so it's not a reflection then of epilepsy disease severity. There's some nice studies from Massot-Touros published last year that look back at patients who had only epilepsy and PNEE and epilepsy to see if there was some characteristics that differentiated between the two groups of patients. And it's more common if you have PNEE to have minor head trauma, migraines, anxiety, and chronic pain. And when you have both PNE and epilepsy, and so you also have that epilepsy component, it's more common in patients that have developmental delay, abnormal MRIs, and if their episodes and seizures are shorter in duration. So sometimes history, can help you have a higher suspicion of which patients you might want to continue to look for epilepsy in. But again, many patients with PNEE, most patients with PNEE will only have PNEE and not have epilepsy. And I think seeing the events on video can be very helpful, or if they happen in the office, for you to have confidence in really what the clinical semiology is that they're experiencing. and then that EEG evaluation and a prolonged one, again, up to 24 to 48 hours to screen for those interictal abnormalities that might make you then have a higher concern for a dual diagnosis, although interictal abnormalities isn't the defining feature and certainly would make it a more complicated patient if you still think the events are really epilepsy, but someone that you might want to keep a closer follow up in your own practice to kind of review what's going on at home with the patients.
And that 24 to 48 hours of monitoring, it's helpful if you can do all of the anti-seizure medications, but although that might not be possible in some of the settings where you can only do the ambulatory.
Yeah, I think those that have access to an epilepsy monitoring unit can really be helpful because then I think you can take off the seizure medications at the beginning of the evaluation, which I think can help transition to discharging them off medications and discontinuing medications. Induction techniques like photic stimulation and hyperventilation, even when patients know they're being used to try to induce events, have been shown to be helpful at seeing the events. And independent of the frequency that their events are happening outside the hospital, it's quite common to see non epileptic events occur within the first 2 days of the recording. So it wouldn't be expected that they would need a prolonged EMU stay, but I think it can be very helpful if you have access to the epilepsy monitoring unit to really help get that documented, clinically established, unequivocal diagnosis of PNEE.
And then we touched on it a little bit, but the reason we've spent so much time talking about the accuracy of diagnosis is just because it can be helpful, like you mentioned, to discontinue anti-seizure medications in these patients if they don't have epilepsy. So can you talk a little bit about the risks and benefits of discontinuing anti-seizure medications once you've diagnosed PNEE?
Yeah, I think this is what it all comes down to, right? Is should we be exposing and continuing to prescribe seizure medications to these patients? And when patients start having their events, over 75% will end up being on a seizure medication at some time. And the longer it takes for them to get their diagnosis, likely the more seizure medications they've been exposed to. And unfortunately, even after the diagnosis is made, up to 40% of patients will remain on medications. So I think this is why it's really important to review this topic and to talk about it because we know that isn't what is now medically recommended based on what we know about this disease. PNEE is not epilepsy. Seizure medications are not indicated. And exposing patients to seizure medications unnecessarily can lead to medication side effects and can lead to mismanagement in the emergency room setting when the diagnosis isn't clearly differentiated from epilepsy. In studies that's looked at this and followed patients, whether they continued medications or discontinued medications at the EMU discharge or at follow up, there were higher rates of remission in those who discontinue medications at the time of diagnosis compared to follow up. And there are higher rates of complete resolution of events if they're able to leave the epilepsy monitoring unit off anti seizure medications completely. And this has been studied in some retrospective studies, and then one nice, albeit small, randomized controlled trial by Otto's group that was published in the Epilepsia Journal. Resolution of events is not paired with high or low frequency. So even if patients are coming in with really high frequency of events, it can still and should be the plan to have them discontinue medications, and it is safe for them to leave the epilepsy monitoring unit off medications. Also, in patients with that dual diagnosis, if you're able to differentiate between the events, and if patients are able to understand and differentiate themselves, then if medications had been increased for what then is diagnosed as PNEE events, it's also been found that you can safely minimize and decrease seizure medications when you're focusing them around those PNEE events. So practitioners shouldn't feel like they have to keep medications at high doses or multiple medications if, when looking back, it was clear that those medications were increased or added for PNEE events in those with a dual diagnosis. I think it's important to emphasize that accurate diagnosis and discontinuing of medications that can lead to resolution of events, but then it also leads to decreased use of emergency medical services. And given that PNEE events are characterized by prolonged events, they can be misdiagnosed as status epilepticus. And so there can be real adverse effects by not approaching the management correctly and leaving patients on seizure medications inappropriately.
What else should we try to remember? What are the clinical pearls we can take when we're thinking about diagnosing and managing patients with PNEE?
Early and accurate diagnosis is key to the first step in managing these patients. And trying to decrease that delay from symptom onset to diagnosis can impact their prognosis and help resolution of events. It's important to validate patients that their symptoms are real and non volitional while also emphasizing that it's different than epilepsy. Seizure medications are not recommended for the treatment of this disease and should be discontinued, but it's always important to ask, is there other indications why patients are on these medications? For example, someone might be on lamotrigine for depression, Depakote for migraines, and certainly there then are instances when a medication is continued, but it should be clear that they're not for the non-epileptic events and therefore the other indication. Both those key factors, an accurate diagnosis and discontinuing of medications, can lead to resolution. And there are variable rates listed in the literature, but it's on average around 50%. So there's certainly going to be a lot of patients in your practice that the disease persists. Psychiatric care is then an important component, and there's an emphasis on cognitive behavioral therapy treatments being effective above and beyond basic therapy techniques alone. Another takeaway that I want to emphasize is that a hallmark symptom of PNEE is that there's variability and there's non-stereotyped characteristics to the events. And it can be a challenge when retesting is needed. And I think that's where a neurologist's follow-up care can be a key component to this disease. A neurologist can provide reassurance that the symptoms are still consistent with PNEE and can have the clinical acumen to know when retesting is indicated and when you have a higher clinical suspicion for that dual diagnosis. So while at some point treatment has to transition into mental health care and psychiatric care, oftentimes the question is, how and when should a neurologist still be involved? And I think that's really the key position that a neurologist can play in the follow-up care of these patients, is when you're taking your history and hearing them still have events in those patients that don't have resolution, you can provide reassurance that this is still the same disease and help them try to focus on psychiatric care and mental health care that can be valuable, and reassure them that seizure medications really can cause harm and that are still not indicated. Well, there's a lot of patients out there that I think neurologists can have a big impact on, because we really are the most well trained to diagnose this disease and then often have the most comfort in discontinuing medications. We certainly need more research on interventions for those who the disease persists. And I'm hopeful that in the years to come, we can provide some more options to patients.
What I love about this talk and the information you've provided is just helping us keep in mind that sometimes we think we don't want to be too quick to diagnose somebody with PNEE. So we try to keep that kind of just in case, or like, well, that level of doubt because we're worried about they're going to go and have a seizure. But the information you provided has really helped highlight that keeping that level of doubt just in case can actually do a lot more harm for these patients. So it's good to do the proper workup and then be confident in your diagnosis and relay that confidence to the patient. So again, thank you so much for joining us today, Genna, and we will link some of those articles that you talked about in today's show note. Thanks again.
I know this can be a really difficult disease for all of us to deal with in our offices, but knowing you have confidence in making an accurate diagnosis and that can really impact a patient's disease trajectory is certainly something I hope you take away from today.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.